Alright, good morning everybody. Welcome back to Pathagonia. So we're going to continue with part 3 of our CNS tumors Kurt's Notes series. Hopefully we'll finish this time. That was a pretty long PDF, so I broke it up into a few episodes. So this category is neuronal and mixed neuronal glial tumors. So first up we have dysembryoplastic neuroepithelial tumor, or DNET, which is WHO grade 1. This is a benign glioneuronal neoplasm, usually in children or young adults, typically in the temporal lobe, and it can present with epilepsy or seizures. I've seen this entity come up a lot in question banks. It's a younger patient, a child or a young adult, and they're presenting with seizures that are refractile or not responding to treatment. So on histology, you're going to have columns of small, round, monotonous cells. They have an oligodendroglioma-like appearance, and they can be oriented perpendicular to the cortical surface formed by the axon bundles. And then you'll see normal neurons floating in mucin pools, as the arrows indicate here. So we have these neurons, and they seem to be in these pools of mucin. They can have a multinodular architecture, and then molecularly you can have presence of an IDH mutation or codeletion of 1p19q excludes this diagnosis. So 1p19q we associate with oligodendroglioma, remember that. And DNETs have an excellent outcome. Next up we've got ganglioglioma, WHO grade 1. So this is a well-differentiated, slow-growing lesion, often in the temporal lobe of young children. Also can have a cystic appearance and frequently presents as well with early onset epilepsy or seizures. Histologically, you're going to see dysplastic ganglion cells with dysmorphic neuronal features without the architectural arrangement or cytological characteristics of cortical neurons, with neoplastic glial cells. May resemble an astrocytoma, oligodendroglioma, or pilocytic astrocytoma, and can be heterogeneous within the tumor. So molecularly, for a ganglioglioma, you're going to have a BRAF V600E mutation in about a fourth of these, presence of an IDH mutation or codeletion of 1p19q, again, would exclude this diagnosis. These also have excellent outcomes. Of note, if you have increased cellularity, pleomorphism, mitotic figures, microvascular proliferation, and or necrosis within the glial component, consider anaplastic ganglioglioma, WHO grade 3, with uncertain outcomes. Alright, gangliocytoma, WHO grade 1. This is rare, slow growing, and usually in children with epilepsy. So that seems to be a theme, right? So younger patients presenting with epilepsy or seizures, there's various brain tumors that can cause that. Composed of irregular clusters of mature neoplastic ganglion cells, often with dysplastic features, and the stroma of non-neoplastic glial elements. These may be hard to distinguish from a ganglioglioma in some cases. They exist on a spectrum. And dysplastic cerebellar gangliocytoma, or Lhermitte-Declos disease, probably pronounced that incorrectly, but that's alright, is rare, benign cerebellar tumor and dysplastic ganglion cells that conform to existing cortical architecture. So this is a major manifestation of Cowden syndrome, which we know is associated with the mutation of PTEN-PTEN. Alright, next up we got papillary glioneuronal tumor, which is WHO grade 1. It's a low-grade biphasic neoplasm with prominent pseudopapillary architecture, which we see with 1. Intervening collections of neurocytes with medium-sized ganglion cells with neuropil at 2. So that's the biphasic. It's got 2 different components. And it can have fibrillary or a microcystic background. and it's often in the cerebral hemispheres near the ventricles. Often occurs in young adults and can be circumscribed. And then there's a frequent molecular association with papillary glioneuronal tumor, and that's SLC44A1 PRKCA fusions, and these have a good prognosis. All right, next up we've got desmoplastic infantile astrocytoma, DIA, and ganglioglioma, DIG. These are WHO grade 1, rare neoplasms of early childhood. They're always supratentorial, often large and cystic, and they may have a leptomeningeal component. There's prominent desmoplastic stroma with a neuroepithelial population of astrocytes, possibly with a mature neuronal component, and abundant connective tissue may lead to prominent reticulin, which may mimic a mesenchymal tumor, and these have a good prognosis. All right, next up we've got rosette-forming glioneuronal tumor, or WHO grade 1. So there's two distinct components to this entity. That's uniform neurocytes forming rosettes and or perivascular pseudorosettes, and also an astrocytic component resembling a pilocytic astrocytoma. So these are slow-growing, relatively well circumscribed, most commonly occurring in the fourth ventricle, and typically occur in children or young adults. For molecular, you're going to have a PIK3CA and FGFR1 mutation with a relatively good prognosis. Next up, diffuse leptomeningeal glioneuronal tumor. These are rare, usually occurring in young children, in the spine or intracranial, and there's often predominant and widespread leptomeningeal growth with oligodendroglioma-like morphology. Neuronal differentiation in a subset of cases can occur, and it's usually low grade appearing with occasional anaplasia. So the molecular for this is frequent KIAA1549 BRAF fusions and either 1p deletion or 1p19q co-deletion in the absence of an IDH mutation. Not currently graded, they're too rare, and there's slow progression over many years. Next up, we've got central neurocytoma. This is a WHO grade 2 lesion, uncommon, interventricular, and often lateral, usually occurring in young adults. There's uniform round cells with speckled chromatin and a neuronal immunophenotype, which would stand for synaptophysin and negative for GFAP. Fibrillary areas may mimic neuropil or ependymal pseudorosettes. And central neurocytomas have a favorable prognosis. Also, you can have an extraventricular neurocytoma, which is WHO grade 2, which can present throughout the CNS, often the cerebrum, without ventricular association, well circumscribed and slow growing. And histologically, these are similar to a central neurocytoma, but with more varied appearance, with a wide age range, often middle age, and you must rule out a diffuse glioma, and then make sure there's no IDH mutations, and these have a favorable prognosis. And just in the other category real quick before we move on, we have cerebellar liponeurocytoma, which is WHO grade 2, and this is a rare cerebellar tumor with a mixture of small neurocytic cells with regular round nuclei and focal lipoma-like changes. Adults, typically with a favorable prognosis. And we also have paraganglioma, WHO grade 1, so this is like elsewhere in the body, has a Zellballen nest of cells appearance, surrounded by a delicate sustentacular network, and it's most common in the cauda equina and jugulotympanic regions. All right, we made it to another category, folks. So embryonal tumors. So medulloblastoma, very common, WHO grade 4. So this is the most common malignant brain tumor of childhood. It arises in the cerebellum or the dorsal brainstem, blocks CSF flow, leading to increased intracranial pressure and a short history of headaches, nausea, or ataxia, with a propensity to spread through the CSF. Histologically, we're going to have embryonal neuroepithelial tumor consisting of densely packed, small, round, undifferentiated cells, as we see here, with a high nuclear to cytoplasmic ratio, variable rosettes. These are Homer-Wright rosettes, usually mild to moderate pleomorphism, with a high mitotic rate. So for IHC, for a medulloblastoma, we're going to have diffuse synaptophysin with focal NUN, and currently it can be classified by molecular or histologic findings, but ideally it would be both. And there's some commonly altered pathways in a medulloblastoma, and that's the sonic hedgehog pathway and the Wnt pathway, which is often through CT and NB1 or beta-catenin. So here's what a medulloblastoma may look like histologically. We see those Homer-Wright rosettes and the small round undifferentiated cells. And then this table, I'm going to let you all review on your own, to going over some of the molecular. I think it would be pretty nuanced for me to try to go through this, and it may be more effective for you all just to take notes on it or to make flashcards from it or reference it rather than me just reading the table off to you. But here it is, excellent table, really nice to have everything organized like this so we can reference it. So there's some histologic subtypes of medulloblastoma, including the classic, which is what we saw on the last page, the most common histology. But we can also have desmoplastic and nodular. So that's what we see here in this top right image, with this nodular reticulin-free zones, or pale islands, with intervening densely packed, poorly differentiated cells that produce an intercellular network of reticulin fibers. So there's significant overlap between desmoplastic nodular and extensive nodularity. Both have the sonic hedgehog pathway, TP53 wild type, a good prognosis, and they're often considered together. So the extensive nodularity, as shown down here, is when you have many large reticulin-free nodules of neurocytic cells against a neuropil-like matrix with narrow internodular strands. All right, moving on, we have anaplastic subtype, which has marked nuclear pleomorphism with particularly numerous mitoses and apoptoses with frequent nuclear molding and cell wrapping. And again, there's large overlap between anaplastic and large cell. They're often group 3 or sonic hedgehog, TP53 mutant, high risk, and they're often considered together. And then with large cell, you're going to have large monomorphic cells with prominent nucleoli. Next up, we've got embryonal tumor with multi-layered rosettes, C19MC altered. So this is WHO grade 4, and it includes the previous entities of medulloepithelioma, ependymoblastoma, and an embryonal tumor with abundant neuropil and true rosettes. There's a defining molecular alteration of C19MC on microRNA upregulation via amplifications and fusions. This has variable morphology, often including multi-layered rosettes, consisting of pseudostratified neuroepithelium with a central round or slit-like lumen, numerous mitotic figures, fibrillary neuropil-like areas, often occurring in young children, most often cerebral, with an aggressive course. And you can see where these are rosettes, and you can see where they could be called multi-layered, right? It looks like we have like a rosette here, and then you think of it as like other layers of rosette around it. At least in my mind, that's something that helps it make sense. All right, moving on. ATRT, or atypical teratoid rhabdoid tumor. This is WHO grade 4, most often in young children with variable location. You're going to have rhabdoid cells with eccentric nuclei with vesicular chromatin and prominent nucleoli, abundant eosinophilic cytoplasm, abundant mitoses, geographic necrosis, and most tumors contain other poorly differentiated elements with neuroectodermal, epithelial, and/or mesenchymal differentiation, including a small cell embryonal component, spindle cell component, or even gland-like areas. So for molecular or IHC, which is required for diagnosis, for an atypical teratoid rhabdoid tumor, you're going to have loss of SMARCB1 or INI1, which is part of the SWI-SNF chromatin remodeling complex. And then on IHC, these are going to stain positive for EMA, SMA, plus minus for GFAP, cytokeratins, and synapto. And the Ki67 is usually over 50% for these lesions, which would track with them having an aggressive course with a high proliferative rate. And if INI1 and BERG1 are intact, or you're unable to test for these, then it's going to be a CNS embryonal tumor with rhabdoid features. And you can appreciate that rhabdoid morphology in the images to the right. All right. CNS embryonal tumor, not otherwise specified, is WHO grade 4. And this is just going to be a poorly differentiated embryonal tumor of neuroectodermal origin that do not have the histopathologic or molecular alterations of the tumors listed above. High grade with aggressive clinical courses. So if you can't histologically or molecularly classify it into one of the tumors that we just went over, then it's CNS embryonal tumor, not otherwise specified, WHO grade 4. So this is a helpful little chart. I am going to go over this one just because it's kind of classic as far as some biomarkers and then associated tumors. So C19MC amplification or Lin28A expression is going to be that embryonal tumor with multilayered rosettes. SMARCB1 or SMARC4 loss, atypical teratoid rhabdoid tumor. H3K27 mutations, diffuse midline glioma, H3K27 mutant. C11 or F95 RELA fusion gene or L1 CAM expression is a supratentorial ependymoma. IDH1 or IDH2 mutations is adult type diffuse gliomas. CTNNB1 mutations, nuclear beta-catenin. Medulloblastoma, the Wnt activated pathway. And then GAB1 or YAP1 is the medulloblastoma, sonic hedgehog activated pathway. All right, made it to another category. Pineal tumors. So they often block the aqueduct, leading to increased intracranial pressure, headache, papilledema, and brainstem or cerebellar dysfunction or ataxia, nausea, etc. So WHO grade 1, the first entity, is a pineocytoma, which is uniform, small, mature cells resembling normal pineal cells that grow primarily in sheets and often form large pineocytomatous rosettes, which is what we're seeing here. Not in the normal pineal gland, and there could be pleomorphic cells showing gangliocytic differentiation. They are round nuclei with fine chromatin, lots of processes, with no mitotic activity, less than 1 per 10 high-powered fields, and the Ki67 is usually less than 1%. These are rare, usually occurring in adults, with exclusive localization in the pineal region, well demarcated solid mass without infiltration or dissemination, and these have a good prognosis. Unlike pineoblastoma, which is WHO grade 4, which resembles other primitive neuroectodermal tumors such as a medulloblastoma. And this is poorly differentiated, highly cellular embryonal tumor with patternless sheets of small immature neuroepithelial cells with high nuclear to cytoplasmic ratio, hyperchromatic, with frequent mitoses, Ki67 expression over 20% with common necrosis, and no pineocytomatous rosettes, but you may see Homer-Wright rosettes. These most often occur in young adults or adolescents, and they invade nearby structures and spread via the CSF. And these have aggressive clinical course, which tracks with the more frequent mitoses and higher Ki67 expression. And if you just look at these, low power, pineocytoma, WHO grade 1, less cellular, less worrisome, very busy for the pineoblastoma, which is higher WHO grade and higher Ki67 expression. So sometimes just our gestalt and our first look can be more useful than we think. Next up, we've got pineal parenchymal tumor of indeterminate differentiation, or PPTID. So this is an intermediate malignancy between a pineoblastoma and a pineocytoma. You're going to have diffuse sheets of large lobules of monomorphic round cells that appear more differentiated than in a pineoblastoma, with pleomorphic cells may be present. The mitotic activity is low to moderate. Ki67 is a little elevated, often more than 5%, but not quite that 20% that we saw in a pineoblastoma. These are going to mainly occur in adults and with variable outcome, currently without grading criteria. And then you have a papillary tumor of the pineal region. So this is a papillary tumor of the pineal region with densely cellular areas, exhibiting ependymal-like differentiation with true rosettes and tubes. They may have solid areas with nuclei mostly round and stippled. Moderate mitoses with moderate Ki67. IHCs are going to react with cytokeratins. And S100, a neuron-specific enolase, negative for EMA and plus minus for GFAP. Too rare to have grading criteria, and they have frequent local recurrence. So still kind of that same pineal histology that we were seeing in all the last ones, the pineocytoma, the pineoblastoma, and the PPTID. However, this is, we can appreciate, has that papillary architecture with some kind of have a fibrovascular core appearance and some papillary regions. So for the dural tumors, at least for meningioma, I did make a separate video specifically on meningioma, and I went over all of the meningioma notes in preparation for a neuro tumor board that I did a month or two ago, so you can find that on our Pathagonia page, but I am going to skip that for now. Please reference that meningioma video because these are very important neoplasms to be aware of, and I don't want you to miss that information. But moving on, we have solitary fibrous tumor and hemangiopericytoma. So this is a fibroblastic tumor with a histologic spectrum. It was previously considered two entities, but united by genetics, and it's usually dural and supratentorial. So SFT, or solitary fibrous tumor, has a classic patternless pattern of short fascicles with alternating hyper and hypocellular areas with thick collagen bands. And then the hemangiopericytoma has high cellularity and rich network of reticulin fibers, which is what we see here. Both have large, open, branching staghorn vessels. And then for molecular, or IHC, you have the NAB2 STAT6 fusion, which is best identified with the STAT6 IHC. Also, these are going to be positive for CD34 and CD99. And these are graded based on morphology and mitoses. So grade 1, solitary fibrous tumor is considered benign, treat with surgery only. Grade 2, hemangiopericytoma with 5 mites or less per 10 high-powered fields. And then grade 3 has 5 or more mites per 10 high-powered fields, considered malignant, treat with surgery and radiation. All right, some unique mesenchymal tumors. So pretty much any mesenchymal tumor can involve the central nervous system, so also refer to the soft tissue and bone guides for further study of these lesions. An important one to know is a hemangioblastoma, which is WHO grade 1, which has two characteristic components. One is the large stromal cells that are vacuolated with often a clear cytoplasm. And then there's going to be abundant vascularity. So that hemangio aspect of the name is going to refer to that abundant vascularity. And then we have the large stromal cells with vacuolation. Most commonly in the adults, commonly in the cerebellum. You can get anywhere though, and they're associated with von Hippel-Lindau disease or VHL. Molecular, it's a VHL tumor suppressor in activation in both the sporadic and VHL associated cases. For IHC, stromal cells are going to be positive for inhibin and brachyury, with endothelial cells expressing vascular markers such as CD31, 34, and ERG. And this is important to differentiate from metastatic clear cell RCC, especially in the setting of von Hippel-Lindau disease. In contrast, RCC stains with PAX8, AE1, AE3, CD10, and EMA. All right, moving right along. So we got germ cell tumors. So for more info, refer to the testicle and ovaries guide, but these are morphologically identical to their gonadal counterparts. So usually occurring in children or adolescents, usually in the midline, and most commonly in the pineal gland. Symptoms are going to depend on location. They can be a mixed germ cell tumor. So you can have germinoma, which is large polygonal cells with clear to eosinophilic cytoplasm, distinct cell membranes, vesicular chromatin, and prominent nucleoli, as we see here, with fibrous septae and nested architecture, with a lymphocytic infiltrate and sometimes granulomas. Next up, yolk sac tumor. This can have many patterns and architecture, often has hypocellular myxoid areas, and most commonly you're going to have this reticular microcystic background with hyaline globules and those classic Schiller-Duval bodies in the hyaline globules, as I mentioned. And you can also have elevated serum AFP. So embryonal carcinoma, these are going to be large primitive cells with vesicular nuclei with prominent nucleoli, with a coarse basophilic chromatin, amphiphilic cytoplasm, variable architecture, nest sheets, and glands, and these are going to be pretty aggressive. Choriocarcinoma, so this is composed of malignant cytotrophoblasts, or mononuclear, and syncytiotrophoblasts, or multinucleated cells, with abundant hemorrhage, elevated serum or CSF HCG. And next up, we've got teratoma. So teratoma is actually composed of tissue from 2 to 3 germ layers. Pretty interesting as far as their pathophysiology and their derivation. So some common elements you'll see in a teratoma are skin with adnexal structures, like maybe some sebaceous glands or some kind of glands. You can also see cartilage, some components from the GI tract, brain, etc. In a mature teratoma, it's going to be exclusively mature adult type tissue, and immature teratomas have immature or fetal embryonic tissue, and with malignant transformation can lead to a somatic malignancy developing in a teratoma. And then just some of the germ cell IHCs I'll let you reference on your own. I guess just high fly overview, some of the ones that stand out to me that I think of being as kind of pathognomonic. Yolk sac tumor, they don't have it on here, but AFP I think is pretty useful for that. Obviously Glypican 3 and choriocarcinoma I think of with like HCG being a distinguishing thing. And then embryonal, CD30, doesn't seem to often stain with any of the other ones, but embryonal it seems to pop up. But embryonal also stains with SAL4, OCT3/4, and others. And seminoma, positive for OCT3/4, SAL4, and CD117. And it's good to contrast seminoma staining pattern with the spermatocytic tumors, but reference the gonadal documents for that, and we'll go into that in a further episode. All right, so like anywhere else in the body, in the CNS, you can get lymphomas, which are going to have discohesive cells with scant cytoplasm and frequent perivascular infiltration. So that would make sense that you're going to see an abundance of lymphocytes around the vessels in the brain, which is what we're seeing here, perivascular spread of tumor cells. So DLBCL, or diffuse large B-cell lymphoma of the CNS, is confined to the CNS at presentation, often in older patients with cognitive dysfunction and a single supratentorial mass. You need tissue for the diagnosis. It's important to not give steroids before surgery, as it may cause the tumor waning, make it harder for diagnosis. These are going to be highly cellular with diffuse patternless growth. Often you're going to have necrosis with viable perivascular islands, perivascular infiltration of the nearby brain, and positive PAX5, CD20, and CD19 on IHC. And this is not virus related. However, there is immunodeficiency associated CNS lymphomas, most common in patients with AIDS, and they can be associated with EBV, and they're often multifocal. So some other lymphomas just to be mindful of: you have lymphomatoid granulomatosis, intravascular large B-cell lymphoma, extranodal marginal lymphoma of mucosal associated lymphoid tissue, or MALT lymphoma of the dura. All right, now we're getting to the miscellaneous other tumors category. So melanocytic tumors presumably arise from the leptomeningeal melanocytes, and they often contain melanin, unsurprisingly. You must consider or exclude metastatic melanoma in these entities. On IHC, they're going to be positive for S100, melan A, HMB45, mite F. Ki67 is usually less than 2% in melanocytomas. You can have meningeal melanocytosis, which is diffuse, multifocal benign proliferation of cytologically bland melanocytes in the subarachnoid space that don't frankly invade the brain. You can also have meningeal melanomatosis, which is primary CNS melanoma with diffuse spread throughout the subarachnoid space, often with CNS invasion. You can also have meningeal melanocytoma, which is well-differentiated, solid, non-infiltrative melanocytic neoplasm, as pictured here, and meningeal melanoma, which is a primary CNS melanoma, a solitary mass with aggressive growth. So some histiocytic tumors. Classic, we've got Langerhans cell histiocytosis, which is going to be a clonal proliferation of Langerhans cells. On IHC, it's going to be positive for S100, CD1A, and Langerin. It may involve the CNS secondarily via extension from the bone or primarily. Usually in children, and the cells will have pale cytoplasm with reniform nuclei, classically associated with eosinophils, and a frequent BRAF V600E mutation. You can see all the eosinophils pictured here. I just saw a really nice case of this on Twitter. I will maybe retweet it or mention it, but it's from a neuropathologist at Northwestern. So we have Erdheim-Chester disease, Rosai-Dorfman disease, juvenile xanthogranuloma, and histiocytic sarcoma. All right, next up, moving on, Sellar tumors. So pituitary adenoma is the most common tumor of the sella turcica, usually in adults. Neoplasm of an anterior pituitary hormone producing cells. These are benign, but they can invade adjacent structures with monomorphic neuroendocrine cells, round nuclei with a variety of histologic growth patterns, including diffuse, papillary, and trabecular, like other neuroendocrine tumors. They may have eosinophilic or basophilic cytoplasm, and they may have perivascular orientation. On touch prep, see cellular discohesive homogeneous neuroendocrine proliferation. And then on stains, they're going to be positive for synaptophysin, chromogranin, negative for S100, and reticulin shows dissolution of the normal network. These are subclassified by their hormone secretion, so you can use IHC panel to kind of flush that out, including growth hormone, prolactin, TSHB, ACTH, FSHB, LHB, alpha subunit. So functioning adenomas secrete hormone, and they often present early with symptoms and a tumor syndrome. Silent adenomas do not secrete hormone, but they will stain with the hormone IHC. So non-functional ones are often present with mass effect. So they press on the optic chiasm, causing bitemporal hemianopsia, diplopia, and headache. And usually they're sporadic, but they can occur in MEN1 and Dicer 1 syndrome. The treatment is usually transsphenoidal resection, which is the first choice, but you can also consider pharmacotherapy or radiation. And like we did with the other tables, I'll let you review these on your own. I've always found endocrinology very interesting, the various feedback loops, and if one hormone is elevated, then its precursor is often diminished, etc. So kind of interesting system, definitely something worth reviewing. As someone that loves neuroscience and behavior, I think endocrinology and understanding these hormones go a long way, and they're very interesting to read about. All right, next up we've got pituitary carcinoma. This is defined by metastasis, independent of any histologic finding, very rare, and you must have proven primary tumor. Metastases are usually in craniospinal axis, and they resemble pituitary adenoma with histology and IHC, often having more abnormal cells and proliferation with a relatively poor prognosis. All right, we got pituitary blastoma. These are rare developmental tumors seen in the neonatal period with three components. So small chromophobic and undifferentiated blastomal-like cells, larger patternless secretory cells with round nuclei and abundant cytoplasm, and cuboidal to columnar cells forming glandular-like structures. On IHC, we've got ACTH staining, negative prolactin, TSH, FSH, or LH. And this is associated with Cushing disease. And then on molecular, they're going to have Dicer 1 mutations, and these typically have a relatively poor prognosis. All right, this is kind of a fun one. So we got Craniopharyngioma, or WHO grade 1. These are benign epithelial tumors derived from embryonic remnants of the Rathke's pouch, usually presenting with a mass effect or visual disturbances, headaches, endocrine changes, etc., and nearby gliosis and Rosenthal fibers. So adamantinomatous craniopharyngioma has a bimodal age distribution of the first and the fifth decades, with the basal layer with basal palisading, as we see here. Stellate reticulum, or a loose background, whorls, wet keratin, as we see here. Calcifications and cholesterol clefts, with multicystic areas, and then nuclear expression of beta-catenin on IHC or molecular. Also, we can have a papillary craniopharyngioma, which exclusively occurs in adults and resembles a squamous papilloma. These are going to be non-keratinizing epithelium and fibrovascular cores with typically a solid pattern, no stellate reticulum, no wet keratin or calx. So if you see this wet keratin, it's adamantinomatous craniopharyngioma. However, a papillary craniopharyngioma is not going to have that keratinization or that wet keratin. And then on IHC or molecular for papillary craniopharyngioma, you're going to have a BRAF V600E mutation with positive P63 and CK56, with a generally favorable prognosis, treated with surgery. However, they can be infiltrative and hard to manage. Some non-neoplastic lesions of Rathke's cleft. So this is going to have no nuclear beta-catenin or BRAF V600E staining. You can have a Rathke's cleft cyst, which is going to be a cyst wall lined by columnar or cuboidal epithelium, which is often ciliated with mucinous and goblet cells. It may rupture, including a xanthogranulomatous reaction. And then you have xanthogranuloma, or cholesterol clefts, foamy macrophages, multinucleated giant cells, chronic inflammation, necrotic debris, and hemosiderin. May see scant epithelium from Rathke's cleft cyst remnants, and epidermoid cyst, which is unilocular cavity lined by squamous epithelium and filled with dry, flaky keratin, like elsewhere. Granular cell tumor of the Sellar region, WHO grade 1. Epithelioid to spindled cells with abundant granular eosinophilic cytoplasm, full of lysosomes. Then on IHC, these are going to have diffuse TTF1 staining, and they're possibly on the spectrum with the two entities below. These can arise in the posterior pituitary or the neurohypophysis or the infundibulum, and they typically have a slow progression and benign clinical course. All right, next up, pituicytoma, WHO grade 1. This is a low-grade glial tumor composed of bipolar spindled cells arranged in a fascicular or storiform pattern. It's going to stain for TTF1 and S100, and possibly on a spectrum with the above and below diagnoses, and it's going to be in the posterior pituitary or the infundibulum. So you can kind of see that spindled pattern that it's talking about there. Next up, spindle cell oncocytoma, WHO grade 1. Spindle to epithelioid oncocytic non-neuroendocrine neoplasms of the posterior pituitary gland with variable pleomorphism. Positive for TTF1, S100, and EMA, and possibly on a spectrum with the above two diagnoses. All right, almost there, folks. So metastatic tumors. So metastasis are the most common CNS tumors in adults. Usually, as we mentioned in the very beginning of part 1, it's going to present with multiple lesions if it's a metastasis versus a primary CNS process. It's usually going to be well circumscribed as opposed to an infiltrative diffuse glioma. And 80% of the metastasis are to the cerebral hemispheres, particularly in the arterial border zones at the gray-white junction. Often presenting with signs of increased intracranial pressure, like headache, altered mental status, ataxia. And the most common sites of origin for men are from the lung, the GI tract, melanoma, or a kidney. And then for women, the lung, breast, GI, and melanoma. So next up, we've got some tumor syndromes. And again, I'm going to let you all review these on your own. I think we've gone over more than enough in the previous parts so far. And I think just referencing these, particularly the syndrome, what gene they're associated with, and then some of their manifestations, specifically their nervous system tumor manifestations, will be highly relevant just to consolidate everything we've gone over so far. And then lastly, at the very end, I would recommend going over this pattern-based approach from Dr. Perry and Dr. Bratt. It's modified from the book Practical Surgical Neuropathology. So some general comments. Although a pattern-based approach is very useful, in many cases you might have a good idea of the diagnosis via instant pattern recognition. Nevertheless, it can be helpful to judiciously consider mimickers and other diagnoses based on a pattern-based approach. So I like pattern-based approaches in any system in pathology just because it kind of helps us form a differential diagnosis and start to put things into different categories. So again, I'll let you review this on your own, but some of these patterns, you're going to see parenchymal infiltrate with hypercellularity. You might have a solid mass, a solid and infiltrative process, destructive or necrotic process, a vasculocentric process, an extraaxial mass, and almost normal tissue with very subtle changes. And then you may have meningeal or CSF infiltrate. And that's it. We finally made it. 3 parts, and you still have some work to do on reviewing various tables and things on your own, but I think we did our best in going through this. I know it's something I'm going to have to reference often to go back through to study, but that's how it all begins, right? We put in the effort and just get started, and then we build upon that foundation. So thanks for joining me, and if you liked it, please like and subscribe, and have a good day.